Dr. Silva, and today I'm going to talk about venlafaxine, Effexor, and o-desmethylvenlafaxine, Pristiq. These are medications that are related because one is the parent compound of the other. Pristiq is the active metabolite of Effexor. So when you take Effexor, you're taking Pristiq. They are SNRIs, serotonin norepinephrine reuptake inhibitors. So they differ from the SSRIs like Prozac, Zoloft, Paxil, etc. in that in addition to blocking the reuptake of serotonin, which increases serotonin, so they're serotonergic, they also block the reuptake of norepinephrine. Now this is a dose-dependent phenomenon, so at the lower doses you get primarily serotonin reuptake inhibition. 75 milligrams of Effexor for most patients is basically an SSRI. Then as you increase the dosage on up to 225 and beyond, you start getting the norepinephrine reuptake inhibition. You get the noradrenergic actions. It's noradrenergic because it's noradrenaline, norepinephrine, noradrenaline, epinephrine, adrenaline. And certainly above doses of 225, you really are getting the SNRI mechanism. And it also has a little bit of dopamine reuptake blockade. And that may not be clinically significant, but at the higher doses, at doses certainly 375, which is considered the maximum dose, or if you dose it higher than that, you may be getting significant dopaminergic action as well. So it has the potential to increase all three monoamines. And it's worth noting also that in the frontal cortex, dopamine is inactivated by the norepinephrine reuptake pump because there's no dopamine reuptake pump in the frontal cortex. So when you block the reuptake of norepinephrine in the frontal cortex, you also have a dopaminergic action because dopamine is enhanced in that way. And that's true of all SNRIs, or all noradrenergic reuptake inhibitors. When Effexor came on the scene, I was just starting residency, and I remember that my preceptor, who was a fourth-year resident, she was about to graduate, and she was so excited about Effexor because it added norepinephrine reuptake to serotonin reuptake. And now we had norepinephrine reuptake inhibition for decades in the tricyclic agents, the first generation antidepressants, which are also SNRIs, but they are very much more toxic. They have a lot more side effects, they hit a lot more receptors, and they are lethal in overdose. Effexor can be lethal in overdose as well, but it is safer than the tricyclics. It is thought to be, though, more dangerous than the SSRIs. It would be very difficult to overdose on an SSRI if you just overdosed on an SSRI. You could take a whole bottle of Prozac and you're almost certainly not going to die. But Effexor can affect the heart, and in fact in the UK, only specialists can prescribe Effexor and Pristiq, and they are contraindicated. They are formally contraindicated in patients with cardiac conditions. That's not so in the United States. I certainly don't get an EKG in my patients that I prescribe Effexor to, but I do monitor their blood pressure, and that is something that you have to worry about because any medication that increases norepinephrine, that will cause vasoconstriction in the peripheral vasculature, and that can raise blood pressure. And so you absolutely need to monitor for drug-induced hypertension. That's also true of the SNRI duloxetine Cymbalta. And again, it's a noradrenergic effect. Effexor is FDA approved for depression, generalized anxiety disorder, social anxiety disorder, panic disorder, and separation anxiety disorder. But it's used for all kinds of depressions and all kinds of anxiety states. Pristiq is only FDA approved for major depression. The FDA approval for medications, it's important, but it's somewhat administrative in that you have to spend a lot of money and many years and do clinical trials, phase 3 clinical trials. It takes a long time. And so just because you don't have FDA approval, just because a drug company didn't decide to spend the hundreds of millions of dollars that it takes to get a FDA indication for a drug, that doesn't mean that it's not clinically relevant, and that certainly that prescribers don't use it for those indications off-label. One off-label indication for Effexor, and especially Pristiq, is hot flashes in menopausal women. The norepinephrine is good for vasomotor symptoms. It's interesting because Effexor and Pristiq are notorious for causing night sweats. They actually cause vasomotor symptoms as a side effect, and way more than other medications in this class. But they actually help to diminish hot flashes due to estrogen withdrawal in perimenopausal women. And Pristiq may be a little bit better than Effexor. Again, if you take Effexor, you're taking Pristiq, but just looking at those two medications head to head, because Pristiq has more efficacy at blocking norepinephrine than Effexor does, they both have more efficacy blocking serotonin than norepinephrine at all doses. But Pristiq has more norepinephrine blocking efficacy than Effexor, and it is the norepinephrine that specifically helps with vasomotor symptoms in hot flashes. Also, there's some preliminary evidence that these medications might be helpful for fibromyalgia and chronic pain. Duloxetine, which is another SNRI, does have the FDA indication for fibromyalgia and for pain, and certainly there's no reason to believe that any SNRI wouldn't be effective, because at the end of the day, it's the neurotransmitters, right? It's the norepinephrine that is helpful at reducing pain, including neuropathic pain. And so it's not the Cymbalta molecule or the Effexor molecule, but the neurotransmitters that they increase down the line. It's the end result. So, again, it's not proven. There's just preliminary research. We have to have the data, but it stands to reason. Effexor XR, I rarely use anything other than the XR. The XR allows for once daily dosing. It minimizes nausea. It also may be better for preventing blood pressure spikes. And so the only time I've ever used the immediate release is when I'm trying to withdraw a patient from Effexor, because these medications do have a physical discontinuation syndromes. I'll talk about those in a second. Side effects. Well, the side effects are going to be the same as any of the SSRIs, and again, due to the neurotransmitters, right? So it's due to serotonin and norepinephrine. When you increase serotonin, what do you get? Well, you get nausea, headaches, you can get diarrhea. Those are all dose dependent. They tend to get better very quickly. Dry mouth, especially with Effexor, more so than the SSRIs, because you're also increasing norepinephrine, noradrenaline, and so that's a sympathetic neurotransmitter. It's a neurotransmitter for the sympathetic nervous system, the fight or flight nervous system, and so when you get excited, when you get worked up, your mouth is going to get dry. Insomnia is also an issue with this medication, especially middle insomnia. So not so much trouble falling asleep, but waking up a lot in the middle of the night and maybe not being able to go back to sleep, which is called terminal insomnia. These are just terms. It's basically, it affects sleep architecture. It makes sleep shallow, and so that can be a real problem for some people. Sexual dysfunction, of course, due to the serotonin, that is trouble with your orgasm, delayed orgasm, or a completely blocked orgasm, or an orgasm that just isn't as satisfying as your normal orgasms. That's called anorgasmia. That's due to the serotonin. Increasing serotonin can also diminish the libido, which is not usually a problem. It depends on the demographics. So postmenopausal women have a lot of trouble with it, but men, and especially younger men, don't ever complain of it. They don't even notice. A lot of people don't notice because they're just not paying attention to sex, because they're not as interested. So a lot of times this side effect itself masks itself because people just don't notice. And you can also get erectile dysfunction. That can be because you're not as aroused, you're not as excited, or the direct effect of increasing norepinephrine can interfere with the parasympathetic nervous system, which is what is responsible for the erection. You also get, even though it can wake you up in the middle of the night, you also can get sedation during the day. It's a sedentary somnolence. I did another video on that, where if you sit down, and certainly if you lie down, you can feel very sleepy. And it's not related to the insomnia, though, that you get in the middle of the night. It's not related to the fact that you didn't get a good night's sleep. Even if you're getting a good night's sleep, you can still feel tired and sleepy when you're not on your feet, when you're not moving around. And so the key is to try to stay active. Lethargy is sort of a related but separate entity, where you just feel like you just don't have the energy to be moving around and doing stuff. Not talking about motivation, talk about the actual physical energy to move your body and get going. Maybe I would speculate that there might be less anhedonia with Effexor because it does increase dopamine a little bit. But whenever you increase serotonin, you do get that diminished pleasure. Not just sexual pleasure, but just pleasure in all things. And you can really blunt excitement. And some people complain of that. They complain that they have no emotion or they feel blunted. Most patients tend to exaggerate that. They hear about it and they're concerned about it, and so they sincerely report it, but they're not really blunted. But they have a concern about it. And so they complain about it. A lot of times when I hear that as a side effect and I explore it, it's really more of a concern than something that's actually happening, or certainly to the extent that they describe it. They walk around like a zombie, but on their examination, they're definitely not flat. I've talked about hypertension already and the need to monitor that. Venlafaxine has one of the worst discontinuation syndromes. I don't call it a withdrawal syndrome just because I don't want to imply that it's habit forming in the way that drugs that are addictive, particularly substances of abuse, are habit forming. It's not that it induces any euphoria. It's not that that you have to take more in order to reproduce the effect that it has on you, and you don't go into a withdrawal per se. But when you stop taking it, if you don't taper down, particularly if you're on a higher dose, then you can get this dizziness, you can get nausea, stomach cramps, sweating, tingling, paresthesias, dysesthesias, so-called brain zaps. Just, it can feel really awful, and Effexor is particularly bad about it. You can get it with some of the SSRIs as well, especially Paxil and Lexapro, but also Zoloft, and really any of them except for Prozac. You never get it with Prozac because Prozac has an extraordinarily long half-life. The active metabolite of Prozac has a half-life of a week, and so there's no way to cold turkey Prozac. It self-tapers. But that's Prozac. But Effexor is, especially for whatever reason, maybe having something to do with its molecular structure, really gives people a problem. In fact, it's so bad that sometimes if a person is nearly late in taking their dose, if they just forget to take it and they're an hour or two out, this isn't everybody, but some people, if they're just a couple of hours out, they start to get the tingling in the brain zaps, and they're reminded they need to go take their medication. And so it's not a medication that you want to leave town for the weekend and forget. You could also, of course, get rebound irritability and rebound anxiety and that sort of thing. Emotional rebound, which you can get with, again, all of these agents except for Prozac. But it's really the physical withdrawal that gets people that cold turkey Effexor. So you never want a cold turkey. You always want to. And that's when I tend to use the immediate release preparation. If I've been using XR, if we get all the way down to 75, which is the lowest dose that the XR comes in, and the patient, sorry, that's not true, 37.5, and the patient can't come off 37.5 XR smoothly, then there is an immediate release Effexor that we can use, and we can take that pill and break it into pieces if we need to. 25 milligrams of Effexor. Some people, it takes a little while because they're very sensitive to this side effect, but it's not dangerous. It's not going to harm you. It only lasts a few days. So I don't understand when clinicians say that it took them a year to get somebody off of Effexor, because it's just not, there's no reason to take it that slowly, in my opinion. The active metabolite of Effexor is Pristiq. I'm using the brand names, but desmethylvenlafaxine, or Pristiq in the United States, FDA-approved only for major depressive disorder. It comes in fewer doses. There's 25, a 50, and a 100. Now, the standard of care is to start at 50 milligrams. I took Pristiq one time, and it was dosed at 50 milligrams, and I had terrible nausea with it. So I don't see any reason why we shouldn't start at 25 and increase it unless we're in a big hurry. But a lot of patients start at 50 and do great on 50. They never have to increase. And then some patients can be dosed at higher than 100 milligrams. It is more potent than Effexor, than its parent drug, at blocking the reuptake of norepinephrine, but They're both more potent serotonin reuptake blockers than norepinephrine reuptake blockers. So one interesting little tidbit that it's sort of trivia, unless it happens to you, which is that you can have a false positive drug test to PCP phencyclidine, which is a hallucinogenic drug, with Effexor or Pristiq. It's actually the Pristiq metabolite that causes it, but obviously, again, if you take Effexor, you're taking Pristiq. And so you can also get a false positive drug test to amphetamines. So false positive meaning that you're not taking PCP and you're not taking amphetamines, but you go get a drug test. And it's just the initial screening that can turn up a false positive when you take Effexor and PCP. On the confirmation test, when they go to confirm it, then it will not be positive for those drugs. So, but upon screening, you can. When I was fairly new, fairly fresh out of residency, and I had a patient that came in. She was, clearly in retrospect, I can see that I should have given her an SNRI from the outset, because she was soft-spoken, there was psychomotor retardation, and she was reporting symptoms of lethargy and diminished interest. And because I was still kind of green, I gave her Zoloft. And Zoloft also has a tiny bit of dopaminergic action, but it's negligible in most people. Maybe the elderly, you might see some improved cognition, but this patient came back to me and was no better. And in as much as SSRIs calm you down and can also cause that sedation and that lethargy and that anhedonia, if anything, I probably augmented those, but she was depressed and the depression didn't get any better. I gave her an SNRI, thinking, well, I better upgrade her. Let me move away from this class. This class is obviously not working. And she came back to me, and even though she was still kind of soft-spoken and there wasn't a whole lot of energy and excitement to her yet, she told me, yeah, absolutely, immediately, big difference. And Effexor works fairly quickly. We say that these medications can take 2 to 4 weeks to start to work, and the full effect can take up to 6 or 8 weeks or longer, but it just depends on the symptom. Anxiety can take up to 12 weeks for the full effect, but patients really should be better, significantly better within the month, and practically to remission by 2 months if you're dosing it properly and you've got the right diagnosis and you've got the right treatment plan. But she came back to me the next visit, which was 2 weeks later, telling me, this is great. She had an endogenous depression. She had a chemical problem. Okay, she wasn't just having an adjustment disorder. She wasn't reacting just to a situation. She needed medication because there was something wrong with her neurotransmitters. And so she needed a fix, and I gave her the wrong drug, which I would never do today, 30 years later, right? But I was new, and even though my preceptor 4 years earlier had been so excited about Effexor, it didn't dawn on me, And that was because at that time, I really wasn't, how can I say this and not make it seem like I didn't learn anything in residency? This target symptom-based approach that is so much at the forefront of my treatment philosophy and in everything I do, it's even more important than the diagnosis initially, right? Because the diagnosis can be wrong, and sometimes the diagnosis is just a paradigm. Diagnoses in psychiatry are syndromal anyway. A lot of times we don't have a specific etiology. I don't want to get into all of that other than to say that the most important thing is to get the symptoms better. Diagnosis is important because you have to be able to predict the course of the illness. So prognosis and what you can expect, and whether the patient will have to take the medication forever, and what's going on. And whether you're dealing with something that is endogenous or exogenous. Is there something wrong with the neurotransmitter systems or not? But the most important thing at the first visit is to identify what the target symptoms are and to give medication, that whatever medication you're going to give, after you do your risk-benefit analysis, part of the benefit analysis is it going to get this symptom better? Is it going to get this symptom better? Is it going to get this symptom better? Not just, oh, the patient is depressed, let me give an antidepressant, like I did with this young lady. It was a mistake that I made that thankfully I had learned enough in residency that I corrected it when she came back to see me. Maybe I didn't do a good enough job at eliciting her target symptoms, When she first came in, who knows? I don't even know how I made the mistake, but I knew what to do when she came back, and I never made that mistake again. Which is why, P.S., you should always, well, this is going to be controversial, but you should always, if you're going to go see a doctor, go see one who's older. Now, the young doctors are going to tell me, how could you say that? There's a lot of smart young doctors out there, and they're going to be, more on the cutting edge, and they're going to know like more what's. But doctors with experience is what makes you a good clinician. There are a lot of really bad old doctors too, so you're not guaranteed. But experience, there's just nothing. I'm probably going to edit this out because it's so irrelevant, but. So that's it. Those are those two medications. It's the basic. I think of them almost as the same medication. If you take Effexor, you are taking them both. So it's just like when you take Celexa, you're taking Lexapro. Lexapro is in there. So, and I have separate videos on all of those. Thanks for listening.